Dr. Tambu. Some of you I missed in the morning session. Um, I'm going to take the last session for today. I'm going to talk about the next step. Suppose you're interested in doing a systematic review. Now, systematic reviews, as you know, could be part of the Cochrane collaboration. They do a lot of systematic reviews. That is their goal. Basically, a group of NGO doctors from all over the world who do systematic reviews. They're members of a team, and there can be members of the team from all over the world. Are there other people who do systematic reviews? Yes. There's a group in Australia called Joanna Briggs Institute. They also have a set of people who are doing that. And many people all over the world form groups and start doing reviews. Once you get passionate about it and you find new topics to keep doing these ideas. But two big groups which do this are Cochrane and the Joanna Briggs group. The Cochrane has got its own library, the Cochrane library, where you can go and search. So please go back to the evening and search for your own topics of interest in Cochrane library. That's a good place to start to get an idea as to how reviews are being done. So today's last session is how do you go about next? What are the steps in planning a review? That planning step is like imagining you're traveling to a new destination by car. Now with the Google map or with your other, whatever map you use to travel, you open the map and you chart out your route before going. So that's a kind of a roadmap. So you know, okay, where will I stop for breakfast or lunch or dinner, and where will I, sleep at night if that's an overnight journey. So that's a sort of a roadmap. So that roadmap for your systematic review is called protocol. It's a fancy word, but that's what protocol is. It's a sort of a roadmap before you start. So, of course, being a Cochrane person, we say that Cochrane started protocols for systematic review. So they sort of became fancy or became in vogue because of Cochrane. And they said every systematic review has to have a plan which is published in the net on PubMed. So if you have a Cochrane protocol, it is published like a publication in PubMed because your protocol is peer reviewed by experts and they'll tell you whether your plan is good or bad. So that's the importance of having a Cochrane protocol, that it's taken as a publication for your promotion or just for, you can say, I've got a Cochrane protocol, means, hey, that means you've done a lot of work and put a good plan in place. So the important thing is some people don't like systematic reviews. You say you're an armchair expert. Somebody else did all the studies. You sat in your room and collected all the studies and you collected and put them together. In one sense, it's true. It's retrospective research. Other people have done research. You're just taking what is already available and collecting it and putting it together in a format which people can understand. So that is a true thing. So how you search for all the studies in the world, how you collect all of them together, your planning has to be done well. How are you going to look for good studies? How are you going to look for poor studies? All those things are very important in the planning stage. If you don't plan well, you'll never execute well. So that's the rationale for having a protocol. So this is called minimizing bias. Okay, just some words you must get. Why do you do protocol? It minimizes your bias. How can you minimize bias? Study is already done. No. The process of doing a systematic review itself can be biased. If you don't get the correct studies, if you don't do quality assessment, if you don't know how to mathematically combine the data, then your systematic review itself is flawed. And nowadays everybody says, oh, systematic review is the best evidence. And if somebody reads your review, which is poorly done, they may be misled. So to reduce bias in systematic review, you must have a protocol. You learned a little bit about searching for studies. So again, you must plan the search strategy before. And you must write to a library and say, look, if I search this way, will I get all the studies in the world? Like I mentioned, these are published in the Cochrane library, protocols itself, or they're also published in PubMed. So first is transparency. What is transparency? Transparency means anybody in the world can say that, hey, this person is doing this. You can't say, I'm doing a top secret work and I won't share my plans with you. No, your plan has to be published. Even before you started doing the review, your plan is already on the net. That plan is peer reviewed. Now, all of you are doing, senior people, you are doing a neonatology degree. So you all published your thesis and you know that your MD thesis had to go through two experts in your university, whichever university you studied. That is a peer review. So your thesis was accepted by two of your professors from some other university who peer reviewed your. If you send a journal article, the journal editor doesn't accept your article. He sends it to two persons in your specialty who will peer review it and then say if your article is good or bad. So the protocol is also peer reviewed. So very important that you have somebody check your protocol. And it's also a way of the world knowing, okay, this person had planned it and this is where it is available. Lastly, transparency means if somebody wants to check your findings, if they copy your methods exactly, this is what I did. If they copy the same methods, they must come to the exact same conclusion as you. That is also transparency. If I give everything clearly, somebody can copy me and get the same finding. And this is one reason people don't like to publish their protocol, because they're a bit worried if somebody copies me, they may not get the same finding as me. So that's why it's very important to publish your protocol, transparency. Secondly, is accountability. Now, let us say that you're looking at some neonatology topic, whether hypothermia is useful or not, and you say, I want to look at mortality as an outcome. And you also want to look at duration of hospital stay. At the end of the review, you publish only data on duration of hospital stay. The systematic review found that changing the temperature of the newborn decreases hospital stay, but doesn't talk anything about mortality. Then somebody will want to know, like, hey, how come they didn't look at mortality? This is an important outcome. Then they'll go and check your protocol. Now you're accountable. You plan to look at mortality. The peer review group said you must publish mortality as an important outcome, but you didn't do it. So you must, that is one other thing. The other thing is, like, let's imagine you're traveling from here to Chennai. On the way, you decided, let me take a detour. Oh, Mahabalipuram is on the way. Let me go and see that beach and then go to the. So that's a change of plan midway through the action. Can you change your systematic review halfway through the methodology? The answer is no, but sometimes you're forced to, because you planned as well as you can, but you met some unexpected events. The study designs are not working out as you planned. The patients in the studies are not exactly what you want. So maybe should I change my PICO statement a little bit so that I can have more studies inside? It's not a good idea to change your plan ever, but sometimes you have to make it. And in that case, you have to justify. Look, I planned to go this way to Chennai, but now I landed up going to Mahabalipuram, and this is my justification. So you have to be accountable for all the changes you make after you've finished your protocol. So and the reader will decide whether it's a reasonable thing you did or unreasonable. So this is a very important step, that if you change something on the way, you have to document it. Now, duplication. Now, if you look at the net, you will find on any neonatal topic, there'll be two systematic reviews on the same topic. You think, why did somebody waste their time and energy doing the same thing which somebody already did? So if you publish your protocol on the net, somebody else will plan, let me do this. He will search the net obviously before starting and say, oh, somebody is already doing this. Why should I duplicate this? If you don't publish your protocol on the net, you'll end up finding that somebody published your exact same idea a month before you. And then you'll be wondering, what did I do? I spent 1 year doing a review and now nobody wants to accept my review. So where do you register these protocols? You can Google this particular website, Prospero. Prospero. It is maintained by this university in York called Center for Reviews and Dissemination. York is in United Kingdom, not New York. And if you Google that, they'll give you an online form. Who are you? Do you have any training in systematic review? What is your PICO question? What is the study designs you're trying to do? How will you search? Just brief. You can fill it up in 15 minutes online, and somebody will peer review that. The difference in Prospero is the peer review is a little bit brief. They'll just ask somebody, just have a brief look at it. Cochrane will take a big deal about it. They'll send it to content experts, methodology experts, library experts, English experts. So that will take it's a bit more serious an effort. Not to say Prospero is any less, but it generally is a bit quicker process. and you can register your title on Prospero. Tomorrow, when you want to publish your review, if you've got a Prospero registration number, there's a much higher chance of getting it published than telling somebody, look, I never registered a protocol, I had it. But people are always saying, then why didn't you publish it? Like, and who knows what you actually planned and what you actually did? If your plan is never available for anybody, people, you can say, this is what I actually plan to do. I plan to go from here to Mahabalipuram and then to Chennai. I never plan to go directly to Chennai. So that's the advantage of registering on this Prospero. Now, some people will not register on Prospero. There's another website called OSF, Open Science Foundation, OSF. But that is just a registry. Nobody will check and see what you've done. You can just register your name there and say, this is my systematic review. But that is a non-peer reviewed site. I'm not saying it's not peer reviewed totally, but it's much less peer reviewed than having Prospero. So try Cochrane first. Okay, Cochrane not working on Prospero. Then you can also do in Joanna Briggs Institute, but they have their own training methodology. You have to attend to their training. Then you mail your idea to them, and then you have to follow their methodology. So much like Cochrane, that's a sort of a one different universe. Cochrane is one, and most 90% of reviews are just done through Prospero, not through either Cochrane or Joanna Briggs. So the protocol has a structure, and you should follow the same structure because people reading a protocol will expect some information to be given. Otherwise, you can write your own plan and it won't have a structure. Not to say that your own plan is wrong, but if the reader is knowing that, okay, this is what I expect, if you give it to him, then they're happy. So this is the structure of a protocol. A, the title. I'll talk about each of these in a little bit detail in 10-15 minutes. The title is obviously the topic which you have chosen. Background information is one description of the condition. Okay, neonatal hypoxia. Little bit about that. What is the new intervention? Some hypothermia, some new drug or whatever. Describe the drug. How will this work? I'll talk about these in a little bit more detail. How do you think this new drug is going to work? What's the mechanism of action? Then a bit like your research protocol in MDMS, aims and objectives, you can have a broad aim, but objectives are exactly what you're going to achieve. So objectives have to be little specifically written. This is my primary objective. Mortality is my primary objective. Length of hospital stay may be my secondary objective. Methodology, that's all what we've been talking the whole day. What type of studies you're going to choose, where are you going to search, what statistical technique you're going to use. This is all in future tense. I'm going to do all these things. And what are the studies? Participant, you've done PICO the whole day? You're familiar with it? You're tired and bored of hearing PICO. So you'll talk about these are the participants I'm looking for. These are the intervention, the outcomes of my review. So this is in brief about what the protocol should contain. I'll just go into each of these in a little more detail. That's the objective of the next 15 minutes. Sorry, I will complete that part. Search strategy. We'll talk a little bit about what are the sites you're going to choose: PubMed, Embase, Cochrane database, nursing, CINAHL database. I'm not sure if neonatology has its own database. Like cancer will have its own database like that. I'm not familiar with neonatology, but there's a neonatology database. There may be. Obstetric medicine has got a large obstetric medicine database. So you must say, where are you going to search? How are you going to collect the data? Some people will have a paper form. Some people will have an electronic data capture form. Remember, the study is already done. You're collecting data from a published paper. Where are you going to collect it? On a paper form, electronic form? And then the analysis methodology. What statistical techniques you're going to use. So what's left after that? It looks like you almost completed a review. Well, once your protocol is completed, you have to get it published. Then you collect the studies, get the studies, extract the data, do risk of bias assessment, do the meta-analysis, then make sense of it. What did I find? Write a discussion and conclusion and publish it. So this is like 50% of the work done. That's what's remaining. Finally, you write some acknowledgements, which you can write now itself. I acknowledge so many people who helped me and funded me, all those things. Okay. So that's a brief. How do you write a protocol? And this is just like your MDMS. The ethics committee approval has to be in future tense. We are going to do, we will do. Just remember when you publish your final review, some people don't change that. Oh, that's all from the earlier part. I'll just cut and paste that. I'll just write the results and discussion. And the method section is written in future tense. When you write the method section of the final review, it has to be we did, change it to past tense. So that's the thing. Of course, the English has to be in active voice, not passive voice. Again, you did all this for your MDMS. It's, we will search, not like literature will be searched. We will do. Don't write fancy English. Sometimes we tend to want to write better English so that some Westerners will be impressed. But everybody now wants simple English, small sentences. So even Cochrane, when we tried, sometimes they said, no, your sentences are too long and complicated. Break them down to simple sentences. A 10th standard graduate of should be able to follow what you say. Don't put highly technical words in your review just to sound good. Okay, background section, a little bit detail. The person reading your background must clearly understand what you're doing. That's the background section. There should be no doubt what you're doing at the end of your background section. So let us say you're talking about neonatal hypoxia. What's the biology of that? Are there diagnostic criteria? What is the prognosis of that particular condition? How prevalent is it globally? There's a word called glocal. We are all as Indians trying to think, I want to answer a question for India. I'm only interested. But your review will be read by people all over the world. So glocal means it should be locally relevant. Obviously, it has to be relevant for wherever you are in India. But a global audience will also find it relevant. Not somebody in North America, but any other low and middle income country or some other people in Southeast Asia. So never write it saying that I want to answer the question for people of Maharashtra or only of Jammu and Kashmir or of southern Tamil Nadu. That's not a useful systematic review. It must have a larger audience. Locally relevant, but globally also have some validity. So what is the impact of people? Like if you treat this, will a lot of people be benefited, or it's a very rare disease where only few people will benefit? So you have to sort of sell the story in the beginning. What is this intervention? What is this new drug? What is the dosing of the drug? How often you have to give it? What is the expertise in giving this new neonatal intervention? You have to be a DM neonatologist to give it, or can a nurse? How can it be done remotely over the telephone so that some remote place where nobody can be done, it can be done by telemedicine? So this is a description of the intervention and the expertise needed to give it. Then comes the theory part of it. This intervention will work by this methodology. Obviously, if it's a drug, you have to talk about the pharmacology. It's absorbed like this, it goes, and this is the first messenger, second messenger, and this is the biological rationale. On the other hand, you may do education, maternal education to reduce neonatal death. Then you're right, okay, how will maternal education reduce it? Educated means that the mother will recognize this much faster than a non-educated person. So write some bit of theory as to how you think your intervention will work. It's a little more difficult to write this section in non-pharmacological interventions, but many interventions now are not pharmacological. They are lifestyle changes or educational interventions. You write how it will work. Lastly, the importance of the review. Why should this review be read by many people? Now, Cochrane and many other organizations, they're very hesitant to take on reviews because they say, we only want to do reviews of public health importance. So when you write your protocol, you have to write to them and say, this is a great public health importance. So you have to sell your story a little bit that it's a really important treatment, important disease. Either economically it's an important thing or it causes a lot of social problems and therefore it does. So these are the things why this review is an important thing to do. The objectives come from your PICO statement, and it's almost like taking your PICO statement and writing it in an English sentence. For these patients, this intervention compared to this for this outcome. But you can't just write it in bullet points. The objective has to be written in an English sentence. So take your PICO and make it into an English sentence for your primary objective, and you will get the objective statement, the primary objective. And that's an easy way of doing it. Write down the PICO and bullet points and make it into an English sentence, and then you got your objective. For example, like this: to assess the effect of oxygen therapy for hypoxia in neonatal children, whatever. So this format usually doesn't include the outcome. So generally, we'll just say the P and the I. You can put the O as well. So you can choose to put the I or no. So this is the way the objective is written: to assess the effect of some intervention for some particular health problem. And you can even specify the setting if you like, in low and middle income countries, or in primary healthcare, or secondary healthcare, or tertiary healthcare. Avoid writing for India or for for Northwest, South India. That we should not do. Now you can also, like your MD, MS thesis, you can have secondary objectives, and you can say, I also want to look at mortality, morbidity, health economics, quality of life. So many other things are my secondary objectives. Once again, like your MD, MS dissertation, don't have too many secondary objectives, because you have to actually go about doing each of them. Somebody's going to check what happened to those secondary objectives. Did you search for them? Did you do them? If you have too many of those secondary objectives, you will drown doing a review. Always try to think whether economic outcomes are important, because you may have a fantastic intervention, it'll be too costly for people to do. So many people will advise you to add economic outcomes, cost effectiveness as an outcome, but then you must be able to collect that data and make sense of the data. Qualitative outcomes, now increasingly everybody's thinking it's not just your quantity of life, it's also your quality of life. Now you may argue that for neonatal child there's no quality of life. I mean, we cannot decide. I don't know, I'm just making fun, but perhaps it's an important thing. How do you estimate the quality of life? So then if you think that quality of life of the mother or the baby is important, then you must write quality of life will also be assessed as a secondary outcome. For policy makers, that's where the whole story changes. They are really interested in the economic outcomes of your study, the quality of life. If you not measured that, then your review will not change policy. So if you do want your review to change policy, put them. Don't worry whether I'll find studies which published economic outcomes or qualitative outcomes. State it in a review. And it's very important at the end of your review to state, no study published economic data or quality of life. At least then the policymaker understands, hey, for this important question, we better do a study, or we must collect data about economic outcome of this, or the quality of life in this particular condition. So that's another place where your review can help. I looked for this important outcome, it wasn't there. So don't worry that, it's unlikely to be there, so why should I look at it? It's important, so state it in your review. Okay, but this is just one example I've taken. You all know Parkinson's disease. It's a disease of the nervous system. And many old people with Parkinson's will be drooling. And people do give botulinum injection now to reduce drooling. So if one were to try to put this into an objective, how would it read? I'll give it 30 seconds to think about it. Use this format. Intervention for the health setting, health problem. Botulinum toxin for Parkinson's disease and drooling. So it looks something like this. To assess the effects of botulinum toxin treatment on drooling in patients with Parkinson's disease. So you can see the PICO part there. The patients are Parkinson's with drooling, not just Parkinson's or drooling. And the treatment is botulinum. We didn't write about the comparison or the outcome and all that. We don't have to put everything in the objective statement. So writing an objective is not complicated, just putting that into words. Next, we'll go on to the method section. And this is where the bias comes in. Like if you're not careful with the methodology, you'll come up with a poor review. So the method section is really an important part of your protocol. So plan out your tasks. Now, just remember one rule. Nobody will publish a systematic review with one author anymore. Right? You'd have heard from Dr. Mohan, risk of bias should be done by two people, data extraction by two people. So you can't say I, me, and myself. So previously, there were a lot of single author systematic reviews. That's true. One fellow sat and did all the work. But now the world won't accept those publications anymore. So if you've got two people, then this is a good place to plan. I'll do this, you do that. So otherwise, you'll land up with the junior person doing all the work, that may be all of you, and your boss will say, okay, well done, and then he won't do. But in an ideal systematic review, right, so and so will do this, so and so will do this, so and so will collect data and duplicate, and so and so will do risk of bias. So that allocation of tasks are very easy. This will give you an idea of how long it will take. How long does it take to do a systematic review? Ideally, 1 year. 6 months from the idea to completing your protocol. From the time your protocol is completed to the review completing, 1 year. But what you said is 3 years is it'll land up with most people's time. You're busy working, you've got your family, you've got your social life, and do the review. So that's the thing. So these professional groups, however, will be very strict with you. They'll give you 1 year. At the end of it, they'll say, hey, what's happening? You'll constantly be barraged by comments and emails from them. Hurry up, speed up. Then they'll be saying, hey, so and so said they'll do like data extraction. They don't seem to have done anything because it's all done on an online platform where they can see who's logged in, who's done what. So that's why it's important. Once again, the method section, it should be in as much detail as possible so somebody can replicate it. If any of you are serious about trying out this, there's a free book online called the Cochrane Handbook. Every step is detailed in exquisite detail there. You can't download the whole book, but you can download small chapters because it's a huge book. It's there free on the net. So if you're interested, you can look at the Cochrane methodology, how to go about doing a review. In a large detail is given free on the net. So this Cochrane Handbook, you can Google and see this is the methodology to follow. Some people say, sir, my question, I know that there'll be no studies. But never write a review thinking I won't find studies. You never know. There may be so many studies in your area which you haven't read about because there are so many databases all over the world, Chinese, European, Iranian. There may be publications everywhere which you haven't seen so because you're tending to read only one particular area of literature review. So write your protocol thinking that I'll get many studies. Don't say I'll exclude studies of non-English. Very often people from India write that. Then how are you going to do? Imagine COVID. If you wrote we will exclude Chinese articles, the first 20 or 30 randomized studies all came from China. So now the world say, no, you can't do that. But then that means you have to take some effort. If you get a Spanish article, you can use Google Translate, or you have to find somebody who can extract the data for you. It's not that difficult. You're not going to get 100 Spanish articles. But whatever it is, don't exclude articles from regions or places for whatever reason. So many people do based on language, I'll exclude, but that's something we shouldn't do. What about unpublished material? Should we include or not? Should include. How do you know it's unpublished? How do you know it's out there? So clinical trial registry. So you must get used to searching clinical trial registry of India, WHO clinical trial registry. If you Google it, WHO clinical trial registry. The United States clinical trial registry is called clinicaltrials.gov. Some people search that as well because it's a large repository. But you must at minimum search the WHO clinical trial registry. Only then you know that some study is going on somewhere in the world. And then the person might not have published it. Then you contact them because the email will be given there. Hello, can you give me your data? Like you've done a good RCT. Can you share your data with me? If they do, it's good. Okay. So I'm just going to quickly tell you, you must talk about the studies. Which studies will be included? What will be excluded? I want only randomized control studies, or I don't mind pseudo-randomized studies. You must decide your study design. What are the outcomes? How will you do literature search? How will you collect data? How will you critically appraise? How will you conduct analysis? What are you planning? How are you going to marry the quality of the data with the quantity? If the studies are all poor quality, will I include them in my analysis or not? What am I going to do with both? You want good quality studies with good methodology. There's a poor quality study. What will I do with that? How will I summarize it? What am I going to do for economic? Some people do the full review and then make a comment about the economic impact. Some people collect economic data from each paper. If you are well versed in health economics, you may choose the former option. That is, collect economic data from each paper and try and combine it. That's a bit tough. A simpler option is to do the whole review and then summarize all the economic data in a separate paragraph. For that, you must plan in advance and tell people, look, this is what I'm able to do. Okay. Eligibility criteria, which studies to include or exclude. Again, PICO you're all familiar with. No need to review that. Patients, intervention, comparison, outcome, and study design. This is PICO. Now, be careful about the setting for your studies. Suppose you want to study the effect of a particular treatment in low and middle income countries. Would you exclude studies from high income countries? I'm interested in the intervention from low and whether it will work in India. Would you exclude studies from a high income country? That's your choice. Some people say include studies from everywhere, then do a subgroup analysis. Low income countries, high income countries, and all put together. That way, you're not excluded everything. All the information is there. But if you take only data from low income countries, then people don't know what happened in high income countries or everything together. But you need to think about this in advance. What am I going to do? Though I'm interested in low income countries, am I going to exclude all the high income country data? So it's your choice. You must decide in advance what I'm going to do. So you must have a thought process, what you're going to do. Secondly, let us say that you want to treat hypothermia by using X device. What happens if somebody else use Y device? It's a slight modification. Instead of the plug being here, they put the plug here, or instead of the heat source being on top, they put the heat source on the bottom. What will you do if the intervention is slightly different from what you want? It's not a drug. Tablets are easy. Some medication is easy. Only that drug, this dose. But if it's some sort of a device or an intervention, or it's a health education, you want health education given in this way, but somebody else gave it in a slightly different way. What are you going to do if papers are published with slightly different from what you wanted? Then you must make a plan. Okay, I won't be so strict. I will also include interventions which are slightly different but have the basic concept similar. So, but you must anticipate these things. If you're very strict and say only this, okay, but you'll have to exclude a lot of studies because nobody would have done the study thinking of you. They have done thinking of themselves. So, don't be too strict. At the same time, don't be too lax. Otherwise, we get a lot of studies. Complex interventions are where they have a drug plus lifestyle modification plus some telemedicine plus some social change. So these are called complex interventions. It's not just simply one or the other. There are many things. For example, in adult medicine, stroke rehabilitation. It is tablet plus diet plus lifestyle plus physiotherapy plus somebody coming to your house and modifying the structure so that you don't fall down at home. So these are complex things. So especially if, I don't know if you have a neonatology, but if you have complex interventions, it will be aware that somebody might have done one of these components differently or might have done 5 out of 6 and left out the 6th. So what will you do in that case? Would you include that intervention or not? So you have a thought process. What are you going to do if your intervention is a bit complex than just a single drug? If you're going to change your protocol halfway because you suddenly realize, hey, I was too strict, I need to loosen up a bit, then you must document clearly. I changed it for this particular reason. Okay, so that rationale has to be documented somewhere. So the change must be transparent. Once again, just to highlight the PICO part of it, if you say I'll take only children with this particular age group who living in this particular area with this economic condition and this no comorbid conditions, that's a very specific PICO you're writing. On the other hand, you may say, I want this review to apply to any child, any neonate globally. Then you just be very broad. Any neonate will be included. So you have to make a call when you're writing a review. Do I want to make my P of the PICO very specific or keep it a bit broad? It's your call. Do you want to exclude some studies? Suppose there's a group of studies where there's neonates and children also. Suppose that only 10% of the participants in a particular study were neonates and 90% are older children. Would you include that study? Suppose 90% are neonates and 10% are older, will I include? So you have to think about this because somebody might have done a study of everybody. Then what are you going to do? then you must pre-specify. No, only at least if 80% of the children are neonates, I'll include that study. So you have a sort of thought, because there may be all sorts of studies out there. And when are you going to exclude studies? Okay, if this kind of study patients are there, I don't want them. So be very clear about saying when you're going to exclude totally a study. Equity. So because we are from India, naturally we keep thinking about money as a thing. But in many countries where there's healthcare is free, they're not really worried about the cost of any intervention or whether people living in remote locations will actually access it, because they seem to have good access. But coming from our kind of background, we must think about the cost of the intervention, accessibility, equity questions. So in your outcomes, you must think about these as well as a flavor. Don't forget that part while doing your review. This is an example. In many Western countries, they say antibiotics should not be given for sore throat. It's a meaningless outcome. But in places where there's a lot of rheumatic fever, then they say that's very important. Maybe if I give antibiotic for every sore throat, rheumatic fever will come down. So I'm just trying to make you think of special situations. The question may be very relevant to India or where you practice. It may not be relevant to some high income country or some other country. So don't negate your own good idea. You saw a patient in practice and you have an idea which you think is relevant to you. It may be relevant to many other people like you. So don't just say that it's not relevant because somebody in the West said not a good idea. So, or vice versa. They may find an idea, a practice worthwhile there. It may not be relevant for us. So you must be open to these kind of things where something may work here, it may not work somewhere else. Importantly, safety should be one of your outcomes. Any new intervention will have side effects. Most randomized control studies, very important point, don't have enough number of patients to tell you conclusively the side effects are more or less. A systematic review is a very good place where you can combine the side effects as well. Hey, after comparing 10 studies, I'm finding out that a lot of the same side effects are there. So side effects should be one of your important outcomes. So in your objectives, make sure that side effects also you're going to compile together. So don't forget that. Subgroups. In adult medicine, we know that men and women respond differently to medication. I'm not so sure about neonates. So you must decide whether I'm going to do subgroups separately of men, of boys and girls, or racial differences, or socioeconomic differences. Are there any subgroups which are of importance to me? You need to plan this in advance. I will subgroup my results and present the data separately in the end. What you plan in advance is called subgroup. After you see all the data and suddenly you get clever idea and you want to do subgroups, what is that called? Post hoc or sensitivity analysis. In systematic reviews, what you planned in advance because you thought it's rational to do that is called subgroup analysis. That will be in your protocol. After looking at the data and suddenly deciding, let me look at that, let me look at this, that's called sensitivity analysis. Post hoc or sensitivity analysis. But you must plan subgroups in advance. Okay, I just want to give you some examples of broad and narrow definitions of intervention. Now, many old people have frozen shoulder. You might have some relatives with shoulder not moving properly. You can say, I'm only looking at particular joint distension therapies. This is a very narrow intervention. I want to distend the joint by putting fluid inside or doing some hydrotherapy or something else. This is a very narrow intervention. Joint distension therapy for frozen shoulder. On the other hand, you may say any treatment I'll take as an intervention for frozen shoulder. So if you want to have a broad definition, they said review of interventions for shoulder pain. The previous one was arthroscopic joint distension for frozen shoulder. Then they decided to say any intervention for shoulder pain, and they got 7 different interventions. So you have to be careful whether you want to go broad, whether you want to go narrow. One of our colleagues did a treatment for Shigella, and it turned out to be one of the largest Cochrane reviews because there were hundreds of drugs people gave all over the world in different situations. They landed up with so many interventions and so many different situations, so it became a mega review. So you must be careful what you want to get on. Do you want a focus question? Do you want to do a broader question? If you're starting off, it is simpler to do a narrow question because then at least you wet your feet in this. Okay, this is something I like. Then I can take on doing a little broader question. Last slide. There's a checklist for interventions. This is very useful for all of you who want to do randomized control studies. The PICO format just says intervention. You'll write, okay, oxygen or sodium or potassium or some drug, whatever you want to do. But people reading that will not be able to replicate because you're not described how that intervention was done. How much drug you took, how much you diluted it, over how much time you gave it, over what drip rate, whether it was given just by a micro drip set or it was given through a TELUMU infusion, what temperature was IV fluid. All these things could be so much different from place to place. Now there's a checklist for that, and that's called TIDIER. Okay, so you can just Google this, it's free to read. It is just telling you if you're doing an intervention study, what all must you describe about the intervention. So increasingly, people are using this checklist to describe their interventions. So I urge all of you to try this particular step. Just Google it, check the checklist down. For your own RCT, even for your cohort studies, if you're talking about some new intervention, use the checklist to describe it. Now, I thought I could Google this to you all. You can actually just Google this and see this one. I'll just take you through one particular protocol to show you what I taught you so far. This is from neonatology, prophylactic intravenous indomethacin for preventing mortality and morbidity. This is one review there in the Cochrane library. So I'm going to open this particular review. I just downloaded it from internet. So these are the authors' names, Fowley, Davis, and McGuire. And it's published in the Cochrane library. Now, I'm not going to take you through it's a full review, but I just want to show you the parts which you have to do next if you want to do a protocol. So it starts from here. I told you background of the, first we start with background, describe the condition. So 1/3 of preterm infants have low birth weight and and hemodynamic and whatever. So there is some description of the particular condition. So it's not much. You just have to write a couple of, see, there's only one paragraph. So what is this condition? So somebody reading this review will recite, okay, this is the condition that they're talking about. The second heading I told you was describe the intervention. So PDA closure may be achieved by pharmacology, by surgery, and or by natural methods. So they have given you some description of the intervention. The next heading is how this intervention will work. How does giving indomethacin work? What's the biology or the pharmacodynamics and biology of this drug going and closing the PDA? You have to give some explanation. Of course, you may say it's so easy, everybody in pediatrics knows. No, but a reader of the review needs to understand what's the mechanism of action. Remember, your review will be read by pediatrician, by policy makers, patients, their relatives. So you must write it in a simple way for anyone to read. Then you must write the objectives. No, next, sorry, I forgot this important heading. Why it's important to do this review. This particular topic is of great public health importance. Next, the objectives. Remember, the objective is very simply written. It's not a complicated thing. To determine the effect of prophylactic indomethacin on mortality and morbidity in preterm infants. Patient group is preterm infant. Intervention is prophylactic indomethacin. Outcome is mortality and morbidity. So you put all into one sentence, that is that. Methodology, what are the types of studies? Randomized studies or quasi-randomized studies? Who are the participants? Preterm neonates, and they have defined it. Intervention, prophylactic indomethacin. Of course, they could have specified the dose and the duration and how much all this, when it's given, what is the how many days before delivery. All these things could be specified or after or whatever. But they have just given this primary outcome: all cause mortality at hospital discharge and recent follow up. They could have said 1 month outcome, 3 month and 6 month, but they have been very general and said at the last follow up. Because you might have done a study and published 1 month outcome, you might have published 6 month outcome, you might have published 1 year outcome. If you want, you can specify. I'm looking at 1 month, 3 month, 6 month outcome. They have been a little. Then they have talked about neurodevelopment and given a lot of neurodevelopment, and they decided all this is primary outcome. A whole list of neurodevelopment. Then they have listed secondary outcome, PDA, LVH, respiratory outcomes, renal outcomes, GI outcomes, hemostasis. So you can put a lot of secondary outcomes, but don't put too many, you will get a wash. Dr. Azaraya taught you about search strategy. Remember, write it in future tense. We are going to search Cochrane library. Remember, the Cochrane library is the largest source of randomized control studies. You don't have to go and search Chinese database, Iranian database, Indian database, MBase. Everything is searched in Cochrane. And they update it every 3 months. So searching Cochrane library itself, you can get large number of randomized control studies. So if you do that itself, you've done most of your search. Then you can say, okay, I'll also search MBase, PubMed. MBase is a paid search. It's sort of a European medical database. You have to pay to search. So many people don't pay and search that. It's fairly reliable to say I do Cochrane library and PubMed. Clinicaltrials.gov, controlled clinical trials. These are for studies which are ongoing. Other resources, okay, they're searching the Pediatric Academy, European Society. You may have a neonatology society, but just remember that every country will have a neonatal society. Are you going to search all their annual conference proceedings? It's quite a humongous task. Or you'll have to say, no, there's only one, the world's best society is somewhere in US. I'll search that society for latest studies which have come there. But if you do that, you have to go and search that proceedings of that particular workshop. Data analysis, the neonatology group has got a standardized form. So don't try to make your own data entry form. Write to that group and say, can you give me your standardized form? I may add some data, I may take away, but at least it's a standardized form which they will accept. Okay, then selection of studies, the title and abstract were searched. You'll have to write that 2 people will search and decide. Data extraction has to be done by 2 authors and consensus by a 3rd author. You'd write this part as well. And we are going to do this. Risk of bias, Dr. Mohan took a large class. You'd write how you're going to do risk of bias, what are the items you're going to follow, and I'm going to do this. So you'd write, I'm going to do risk of bias assessment. Then some statistical part you can write. Am I going to do relative risk, odds ratio, risk difference? One mistake is don't copy and paste from somebody else's review and say, that's very easy, I'll do that. Because then tomorrow you won't understand what you've written there, and then you'll be stuck saying that your protocol said this, but it doesn't make any sense later on. So ask a statistician, does it make sense to use relative risk or odds ratio? What is a simple thing? That's measure. I don't know if you have a lot of cluster randomized studies in neonatology. Meaning one neonatal ICU is does one practice, another city does another practice. So the unit is not the patient, but the ICU, one whole neonatology unit does one thing, another unit does something else. Those are called cluster randomized studies. What are you going to do? Some studies are individually randomized, some other studies are cluster randomized. That is what is called unit of analysis issues. Did Dr. Prasanna talk to you about heterogeneity? So how are you going to deal with heterogeneity? And finally, what software are you going to use for data analysis and subgroup analysis, if you plan subgroup analysis? So that's why your protocol will end. After that, your protocol is published. Then you get the studies from the librarian, or you search yourself, you extract data and you go about and you publish your results. So I know it's a little longer than we planned for the day. Apologize, we're a little overboard and it's a long day. Any questions on protocol? Anything at all? This is definitely not something any of you want to do now. I put you all off. Well, thank you for attending the workshop. Were there any question on the first session on RCT that you want to clarify? Dr. Pratap's session was engaging, I'm sure. Any questions or any other feedback you'd like to give us? On the risk of bias, was that too much for her? Or it was all right, something to start off with? You can do that now by yourself.
One question
Yes.
That is it possible to publish an RCT now, which was done before 2017, which was during the time when the registration was not required?
Yeah, you can, but not in all journals. You'll have to find a journal which doesn't insist on that. You write in the method this study was This study was conducted before registry was mandatory. But many new journals will not accept that publication. Sorry. So you'll have to just search around a journal. It's like journal shopping to find one journal which will accept it. There are some registries, not in India, which accept retrospective registration. So you can register a trial after it's completed. That's not the right way to do, but you can do that. So you can find some countries and see where retrospective registration is available. Register it there and then publish. Yeah, there are some countries where that's allowed. Maybe I'll tell you later. But there are many journals which are not insisting on the clinical trial registry number. They want to be the top tier journals, but yeah, index, but will not be the top journals in your specialty. Any other questions on data analysis by Dr. Prasanna? Any questions you all have?
Is there anything like fixed effect model is superior or random is superior?
Fixed effects, random effects, there's people fighting all over the world, experts also fighting on that. Generally, if your intervention and is very standardized and everybody expects the same results, then you use a fixed effects model. But if you're thinking that the intervention is going to be different, the populations are likely to be slightly different, then you're not going to get the same results. You know before you start itself. So then you might as well use a random effects model. Having said that, this Cochrane or Joanna Briggs, they have some idea like, okay, the infectious disease group thinks that all the interventions are standard, patients are standard. That group will follow fixed effects. Little more lifestyle oriented groups or like complex interventions, they know it's going to be varied. That group will say, no, we'll only use random effects. The simple answer is, with the software, you can just change the analysis with a click of button. If you find the analysis results are very same with both, then it doesn't make a big difference. You can say fixed effects, odds ratio is so much, random effects is this. But if they're widely different, ethical thing is to publish both and say, alert the reader, look, by changing the methodology, the results seem to change significantly. Reader is advised caution. If you don't do that, you can choose which method suits the story you want to tell. Who will understand fixed and relative?
Do you want to mention the protocol?
Usually in the protocol, you'll say, I'm going to use fixed effects or random effects. But if you find the results are widely different, it's good to put a note of caution. However, the two methods available are fixed and random effects, and the results are widely varying. Especially if one is harm and one is benefit. If it's just degrees of benefit or degrees of harm, it's okay. But if one method shows harm and one shows benefit, which can happen, then just alert the reader, look, there's something else here which I can't explain why these two methods are widely different.
Which one to use depends upon the type of studies.
It depends on your question and the type of studies you're going to get. And of course, if you're doing in Cochrane, then that group will tell you, the infectious disease group will say, we tend to use fixed effects. The other group, the statistician will say, but you can always, once the studies come in, the statistical editor themselves say, look, I think we better say that we plan fixed effects, but we'll also present the random effects. So it's present both and then let the reader be aware this is what you found. On literature search, any questions? There's an online software called RevMan. I think by the end of this month, it'll go off from being free. So if you want, you can just Google and download that RevMan software and keep it for you on yourself on your laptop. There's another one called Ryan, RAYAN, Ryan. Yeah.
Protocol deviation allowed, like suppose you've written a protocol and then when you actually start doing the review, you find out there are studies which maybe we now have to improve because earlier we thought.
Yes, you can do, and protocol deviations do happen all the time. But one important thing which I didn't mention earlier, you change your protocol, you must give the reader what happened because you changed your protocol. These are the results which would have come if I didn't change my protocol. These are the results which came because I changed my protocol. Otherwise, what will happen? Oh, if I do my original review, the study is not showing any benefit. But if I change my protocol, suddenly new studies came and my results changed. That the reader must be a bit aware of. Look, I changed my protocol for these legitimate reasons, but having changed my protocol, these are the results. Without changing, these are the results having changed.
So would you recommend that we should actually do a thorough literature search, see what?
No. Do a quick literature search. Write the protocol based on what makes sense to you.
And
then you start the literature search after the protocol is published. That's why it's good to have a team, because somebody or the other would have got the idea which you missed out. Like, hey, let's do that. Why not only this? Let's look at it different way. Why fix? Let's do this. So that's good to have a team of different people and have some ideas to gel around. From our, if any of you are interested in doing a review, you can contact any of us through Jacob or Madan, and we'll put you in touch with Dr. Pratap or Dr. Mohan. They can guide you in doing a review. They may not be able to handhold you, but he can guide you into that. Okay, otherwise, thank you very much for spending the whole day with us. I hope it has been worth your time. Okay.